Good morning. This is Deb Goldberg. I am a BSN student at Aspen University, and I am going to discuss today a motor vehicle accident case review for our medical terminology course final project for week 8. So in this case study, we're going to discuss a young man, a 34-year-old Caucasian male. His name is Don Smith. He was in a motor vehicle accident in which he was an unrestrained driver. He presented to the emergency room with a chief complaint of left lower quadrant pain in his abdomen, pain in his left arm, left leg, and he had head pain. His vital signs were essentially unremarkable except for mild tachycardia, mild tachypnea, and he was hypothermic, and the etiology for that hypothermia is unknown at the present time. He reports no level of consciousness or loss of consciousness changes and or dizziness. The EMTs at the scene did administer immediate first aid, including splinting to his left leg. They placed his left arm in a sling for immobilization, and they did administer first aid to his head for a small laceration on his forehead. While in the emergency room, his physical exam projected the following findings. The patient was awake, alert, with some mild confusion. He had a contusion on his left lower quadrant of his abdomen with complaints of pain. He also had a contusion on his left leg with some swelling and pain and limited range of motion. His left upper extremity was swollen with a large hematoma at the elbow, and there was obviously a bone protruding through the skin of the left upper extremity, and it looked like it may be an open humeral fracture of the left upper extremity. In the ER, when we took the dressings off, it did appear that he had a 2-centimeter laceration on his forehead above the nose with some steady bleeding from that. However, the laceration was superficial and did not need any sutures. We did some stat lab work in the ER, which revealed a blood glucose level of 35, and his other lab results were essentially within normal limits. The blood sugar of 35, more than likely with his history of diabetes, was a probable causative factor for the accident. His other significant medical history include hypertension, high cholesterol, hypercholesterolemia, scoliosis, asthma, GERD, renal calculi, depression, and anxiety. The assessment and plan of this patient in the ER, the differential diagnosis and actual diagnosis include multiple trauma related to his motor vehicle accident. We're going to rule out an MI as a possible cause for the accident. We're going to also look at internal injuries to the abdomen because of his present complaint of abdominal pain and the discoloration of his abdomen, obviously indicating that there is some bleeding there. Due to his head contusion, his head laceration, we're going to look for a subdural hematoma. We're going to look for the presence of a concussion or cerebral contusions. There is obvious fracture of the left upper extremity, and we're going to rule out a fracture of the left lower extremity. And then due to the fact that he had a random blood sugar in the ER of 35, we're going to look for complications of his diabetes. So the plan for Mr. Smith is going to admit him to the ICU for the diagnosis of multiple trauma due to his motor vehicle accident under the service of one of the intensivists. We're going to collect a CBC with differential chemistry profile, a UA, serial cardiac enzymes, serial EKGs times 3 days. We're going to do a toxicology and alcohol screen, and we're going to do arterial blood gases. Radiology tests will include a CT scan of the head and abdomen. He will have a chest x-ray and x-rays of his left lower extremity and left upper extremity. And we're going to consult orthopedics and general surgery just in the event that he may need to go to the OR because of some internal bleeding. Medications and other miscellaneous orders will include to resume his insulin per the hospital protocol based on his lab results, pain management with narcotic analgesics. We're going to keep him NPO until we see what's going on in his abdomen. And we're going to give him 3 liters of IV fluid at 75 cc's an hour, which are essentially a 12-hour bag. So he'll get them over the next 3 days to maintain hydration until we start PO feeding. We also are going to consult, we're going to start our discharge planning process with the case management department to include home health nursing for medication management and diabetic education, home health rehab for PT and OT services. So looking at his body systems, a review of his body systems, including his integumentary system, it's obvious that we did find contusions to the abdomen and left knee, hematoma to the left elbow, edema and pain of the left knee and left arm, lacerations on his forehead, and really nothing else, just some minor scrapes and bruises, but that's basically it. But the major system involvement were the ones that we just identified. The musculoskeletal system, when we looked at that, we saw that there was that fracture, that open fracture of the humerus. He did, on x-ray, have a fracture of the left tibia. He is having some muscle spasms due to the edema in that area. He's got general muscle pain, general myalgias. We are going to look at that orthopedic consult because there's a possibility of an open reduction and internal fixation of both the upper extremity fracture of the humerus and the tibial fracture. We're going to maintain the narcotic analgesics for pain, and we're going to keep him comfortable and quiet. His cardiovascular system, the tachycardia, we think could just be due to generalized pain or hypovolemia, possibly due to dehydration or maybe bleeding. The hypothermia, the etiology right now is unknown. However, his temperature is slowly coming up. We're going to resume his cardiac medications and look for any abnormalities on serial EKGs and unusual cardiac enzymes. He does have a history of asthma, and the tachypnea that we see could be related to abnormal blood gases, hypovolemia, anxiety, or pain. However, his blood gases are normal, and his pulse oximeter, his O2 saturation is 98% on room air. His lungs, he does have some expiratory wheezing due to the asthma, so we're going to resume those bronchodilators, monitor his ABGs, evaluate a chest x-ray, and possibly get a pulmonary consult. His digestive system, due to his diagnosis of GERD right now, which is basically asymptomatic, we're going to resume his H2 receptor antagonists and antacids as needed and monitor for any exacerbations. The male reproductive system, on examination and on patient interview, basically there are no physical findings or complaints at this time, so we're just going to wait and see if anything occurs with that. The endocrine system, now due to his diagnosis of diabetes, we are going to monitor him for episodes of hypo or hyperglycemia and renew his insulin per the hospital protocol in the ICU while we maintain his blood glucose levels. We are going to put him on a concentrated carbohydrate diet, which is recommended by the American Diabetic Association, and we're going to get a nutritional consult for diabetic education. His nervous system, okay, he has a diagnosis of depression, looks like the bipolar type, and anxiety disorder. So he was taking antidepressants and anti-anxiety medications at home, and we're going to resume those, and we're going to add lithium for his bipolar disorder. We are going to have a psych consult come in, and we are going to ask case management to look for outpatient support for him when he becomes dischargeable. So basically, our patient who sustained the motor vehicle accident really didn't have any significant life-threatening conditions that he presented to the emergency room with, and he really only had to be in the ICU for 2 days prior to being transferred to a general med-surg unit. He did not require any exploratory laparotomy for any type of internal bleeding, but he did, however, have to go to the OR to have both of his upper and lower extremity fractures surgically set. Mr. Smith was successfully discharged 7 days after admission from his motor vehicle accident with consults in place for home health. Discharge training and education prior to going home went well. He appeared to understand all and meet all objectives and goals of his hospitalization and discharge process. He does have the support of his wife and his family that are going to assist him, and I feel pretty comfortable that he will make every effort to maintain his discharge plans and keep all of his discharge appointments. That concludes the review of the case study on the motor vehicle accident involving Mr. Smith. I hope everyone enjoyed the presentation, and it was brief and understandable. Thank you very much. This is Deb Goldberg signing off for this review in our medical terminology course, week 8 assignment. Thank you so much.